Hello and welcome to this video on managing your shoulder pain. My name is Dan Gillespie and I'm a physiotherapist and part of the Arms Up research team from the University of Alberta. The purpose of this presentation is to give you the background information related to your shoulder problem before your appointment, where you will discuss the best management options for your shoulder pain. I would like to thank the Edmonton Bone and Joint Center for sharing the resources used in this presentation. This video is also available online as a resource to help you better understand and manage your shoulder condition. The aims of today's session are to review the basic anatomy of the shoulder joint, to discuss the most common causes of shoulder pain, along with your treatment options, including non-surgical care, which involves active rehabilitation and exercise programs, along with pain management strategies. We will also discuss surgical care options, including rotator cuff repair and shoulder replacement. We recognize there is a lot of information to cover. There's no need to take notes, as a link to this video and handouts will be provided for you to refer back to. The shoulder joint is the most mobile joint in the body and allows for movement in all three planes of motion, including forwards and backwards movements, sideways movements, and rotational movements. Several joints work together to allow these movements to happen at the shoulder. The sternoclavicular joint, or SC joint, is the joint that connects the collarbone to the breastbone, circled in green here. The acromioclavicular joint, or the AC joint, is the joint circled in blue, formed between the end of the collarbone and the tip of the shoulder blade, shown here. The glenohumeral joint is a ball and socket joint, circled in red. The ball is formed by the top part of the arm bone, shown here. The socket part is part of the shoulder blade, which is also called the scapula, shown here. The shoulder blade also assists with movement by gliding over the rib cage and is especially important for overhead movements and reaching across the body. When you move your arm, all of these joints work in a coordinated way to allow for movement at the shoulder. This movement is controlled by several important muscles. The rotator cuff is an important group of muscles that work together to provide stability to the shoulder joint. But what exactly is the rotator cuff? The rotator cuff is a group of 4 deep shoulder muscles. These muscles are the supraspinatus muscle, shown here, the infraspinatus and teres minor muscles, shown here. All 3 of these muscles attach from the back part of the shoulder blade onto the humerus, or top of the arm bone. The subscapularis muscle is the 4th muscle of the rotator cuff and attaches from the front part of the shoulder blade, or scapula, shown here, to the top part of the arm bone. The rotator cuff moves the shoulder joint together with other muscles that attach onto the ribs, sternum, and spine. Another very important muscle group are the muscles around the shoulder blade and back. Think of them like anchors in a tug of war, keeping your shoulder blade steady so your arm muscles can generate power and move well. But what happens if you have a weak anchorman in a tug of war, or if they let go of the rope? Everything falls apart. If these anchors are weak because of poor posture, it can throw everything off, leading to shoulder pain and wobbly movements. So strong posture and good shoulder blade movement are key to a happy and healthy shoulder. Now that we have talked about shoulder anatomy, what exactly does the rotator cuff muscles do? The rotator cuff gives you strength with rotational movements such as overhand throwing or reaching overhead. The rotator cuff mainly assists with activities performed at and above shoulder height. In addition to this, the rotator cuff also stabilizes and centers the ball of your shoulder in the socket during arm movements. Because the shoulder joint relies so heavily on the rotator cuff muscles for stability, the most common causes of shoulder pain are rotator cuff related pain and shoulder arthritis. Now that we've talked about shoulder anatomy and causes of shoulder pain, we'll move on to discuss 4 important strategies for managing your shoulder pain, including education, medications, shoulder positioning, along with activity modifications. An important area of education is around imaging. Other than an X-ray, special imaging of the shoulder is generally not required to treat shoulder pain effectively. Most patients with rotator cuff related pain and shoulder osteoarthritis can be managed non-operatively. You do not need an MRI or ultrasound to diagnose shoulder pain, as this does not change the treatment. An MRI is only necessary for surgical planning. An important message is to not wait for an MRI to begin managing your shoulder pain. So how do we manage shoulder pain? It's important to stay active. General exercises like walking and biking can help with overall pain management of the shoulder. Heat or ice can also help with short-term pain relief. You can use whichever works best for you. In general, if it is a new injury or there's swelling in the area, ice is better to reduce swelling and inflammation. It's also important to note that a sling is not required and should be avoided as it can cause increased stiffness and reduced range of motion in the shoulder. Next, we'll talk about medications for shoulder pain. The majority of people with shoulder pain can manage their pain with over-the-counter medications such as Tylenol, Advil, or Aleve. A pharmacist or your doctor can discuss medication options that are appropriate for you. For rotator cuff related pain, take these consistently at first and then as needed as your symptoms improve. With shoulder osteoarthritis, you may need pain medication regularly to manage your symptoms. It's important to not take more than the maximum dose written on the bottle. It's also important to note that opioid medications are not recommended for any type of shoulder pain. Other than oral medications, injections can also be used to treat shoulder pain. One of the most commonly used injections is cortisone, which is a strong anti-inflammatory injected to help with pain control. Cortisone injections are done at radiology clinics, typically guided by ultrasound or X-ray for rotator cuff related pain. They are prescribed to decrease pain so you can participate in your active exercise or physiotherapy program. Cortisone injections should not be used as a standalone treatment. Multiple injections for rotator cuff related pain are not advised, as they can deteriorate the rotator cuff tendons over time. Cortisone injections can also be very effective to manage arthritis pain. How long they last varies between patients. It should be used as needed, with at least 3 months in between injections. Hyaluronic acid is another injectable treatment. Hyaluronic acid injections, or HA injections, can also be used to decrease inflammation and improve joint lubrication, usually with mild to moderate arthritis. It's important to note that there is a cost associated with hyaluronic acid injections. If injections provide minimal relief or very short-term relief, you should stop getting them and consider alternate therapies in addition to medications. Finding a comfortable position for your arm can also be very helpful in reducing shoulder pain. Whether you are sitting or lying down, ensure your arm is supported in a position where you are pain-free and your elbow or hand does not fall or rest behind the midline of your body. Positioning a pillow under your arm can also help you achieve this position and often leads to pain relief. You may find it uncomfortable or painful to lie on your sore or affected arm. Lying on your good side with a pillow supported under your sore arm, as shown by the picture on the left, can really help with this. It can also be helpful to sleep in a more upright position, as shown on the right-hand side, such as in a recliner chair or propped up on pillows in a slightly reclined position. Placing a pillow or folded towel underneath the elbow can help to decrease pain. If you're having a bad night or difficulty sleeping, try sleeping in a sitting position. Modifying the way you perform certain activities can also help you manage your shoulder pain. Certain activities can aggravate shoulder pain, and it's important to modify or reduce the demand on your shoulder if the activity is painful. The general rule is if it hurts, don't do it. It's important to avoid reaching behind the plane of your body, for example, reaching to the back seat of your car. Avoid prolonged or repetitive activity at or above shoulder height until your pain and function improve. It's also important to avoid heavy lifting, pushing or pulling with your arm if painful. Long lever positions, especially when performed against resistance when lifting objects, put significant stress on the rotator cuff and shoulder joint. It's important to avoid long lever lifting and strength exercises, for example, forward and lateral raises with dumbbells. Avoid resisted lifting, pushing or pulling with the arms outstretched away from you. If possible, try to keep loads or objects close to the body when lifting. These activity modifications are specific to people who have shoulder arthritis. When exercising, avoid heavy lifting, avoid weight-bearing activities like push-ups or planks, and avoid high-impact activities like chopping wood, hammering, or chipping ice. High-demand work or recreational activities can make your pain worse. Retirement or change of career is an activity modification that may be discussed if your arthritis is severe. If this is not an option at present, use the pain management strategies mentioned before. Finding new, lower-demand recreational activities may be necessary. Now that we've talked about effective strategies for pain management, we'll move on to talking about exercise-based shoulder rehabilitation along with physiotherapy and the home-based exercise program. It's helpful to think of your physiotherapy plan as a garden. Just like a seed needs water, sunlight, and time to grow into a healthy plant, your shoulder needs consistent care through exercise and activity modifications over time to feel better. It's important to note that while physiotherapy is effective, it's not an overnight fix, as recovery often takes between 3 to 6 months. A physical therapist can help you tailor your program to your specific needs and functional goals. Physio visits should initially be 1 to 2 weeks apart to allow you to work on your exercises and improve between visits. When you are able to work on strength, visits should be further apart to allow time to improve and for the muscle to develop. The ultimate goal is self-management with a home exercise program. You might be wondering what physio should look like. Good physio should include changes over time as you improve. If your exercises are easy and pain-free, this is a good time to go back to your physio to progress your exercises. You should do your home exercises daily, and they should not be painful. Your physio should teach you self-management strategies like rest positions and activity modifications so that you can manage your pain independently. Manual therapy, dry needling, or acupuncture can offer pain relief in the short term. They are used to help you be able to do your exercises independently. Modalities such as IFC or TENS, ultrasound, or shockwave therapy should not be the primary treatment focus and are generally not required, although they can be helpful for pain relief. Passive treatments used alone will lead to poor outcomes for your shoulder. If your physiotherapy is primarily passive, talk to your provider about integrating an active exercise-based approach or change your PT provider or clinic. Exercise-based shoulder rehab is typically progressed through 3 phases. Phase 1 focuses on postural control and improving range of motion of the shoulder. Phase 2 introduces initial strengthening exercises to build basic shoulder strength of the rotator cuff while continuing to work on range of motion and posture exercises in Phase 1. In Phase 3, we move on to functional strengthening exercises tailored to your personal activity goals and specific demands of your shoulder. At the end of this video, we'll provide a full overview of these 3 phases, along with a printable guide detailed with exercises of each phase and instructions on when to progress to the next stage. Now that we've discussed pain management and exercise-based rehab for all shoulder conditions, we will now talk about rotator cuff-related pain. Rotator cuff injuries can fall under 2 general categories. Traumatic rotator cuff tears occur with a specific event that you will definitely recall. Common incidents include falls, fractures, or dislocations. Degenerative or chronic rotator cuff tears occur with gradual onset and no specific event or mechanism of injury. Degenerative change means gradual wear and tear over time. This can be related to activities you have done in your lifetime, related to work or sport. These are normal age-related changes, and they increase with age. Next, we'll talk about some common terms used to describe changes to the rotator cuff. Tendinopathy or tendinosis refers to a degeneration of the tendon's collagen fibers. This is a normal age-related change in the tissue quality. You can think of a pair of jeans where the quality of the denim is getting thinner at the knee. This would be an example of tendinosis. The term partial thickness tear means a portion of the tendon thickness has torn from its attachment to the humerus. These tears can be low grade, for about 50% or less of the tendon depth, or high grade, greater than 50% of the tendon depth. A portion of the tendon is still attached to the bone and the rotator cuff is still functioning. Here the jeans are fraying, but there is no hole all the way through. Lastly, a full thickness tear means the tear goes all the way through the depth of the tendon. The size of the tear can be small, medium, large, or massive. The length of the gap is called retraction. A small tear may only be retracted about 1 centimeter. A massive tear can be retracted more than 5 centimeters. Keeping with the blue jeans analogy, a full thickness tear goes all the way through the tendon, just like a hole in your favorite pair of jeans. When a muscle is torn or not functioning, it shrinks from disuse. This is called atrophy. Think of what muscles look like after being in a cast for several weeks. Disuse causes muscle fibers to be replaced by fatty tissue. Rotator cuff tears with significant fatty atrophy cannot be surgically repaired. It's important to remember that rotator cuff tears increase with age and that this is a normal part of aging. Atraumatic tears are very common, and greater than 95% of people with rotator cuff related pain in their 60s or later do not have surgery and can be managed non-operatively. The good news is that 75 to 80% of all patients with rotator cuff related pain improve with a 3 to 6 month course of physical therapy. The primary focus is education, pain management, and exercise-based active shoulder rehab. Research shows the results of active, exercise-based rehab are equal to surgery. Now that we've talked about rotator cuff related pain, we'll move on to surgical management of rotator cuff tears. You might be wondering how decisions are made about whether surgery is appropriate for rotator cuff tears. Surgery is not recommended for degenerative tears. These types of tears are often difficult or even impossible to repair successfully. If arthritis is also present, outcomes after rotator cuff are usually poor. Smoking and uncontrolled diabetes negatively impact the ability of the rotator cuff to heal after surgery. If surgery is being considered, it's strongly advised to quit smoking and work closely with your doctor to improve blood sugar levels to keep them below an A1C of 8. If the rotator cuff is not repairable, a cleanup procedure or cam debridement may help with pain. This is only done for pain management when conservative treatment fails. This is at the discretion of the surgeon. So when is surgery recommended? Surgical intervention is recommended for traumatic tears in active, healthy persons under the age of 60. Exercise-based rehab before and after surgical repair can optimize surgical outcomes. If surgery is indicated for a rotator cuff repair, this is what you can expect. The rotator cuff repair can be a painful surgery. You can expect to have pain up to 3 to 4 months after surgery. Recovery can take between 6 and 12 months, and extensive rehab is required during the first 6 months to resume optimal functioning. Return to work depends on your job duties. For manual labor jobs, you can expect to be off work for at least 6 months or greater. Next, we'll move on from talking about rotator cuff related pain and surgical management to talking about managing shoulder pain related to osteoarthritis. Arthritis means joint inflammation, and the most common type of arthritis is osteoarthritis. Osteoarthritis is age-related wear and tear or degenerative arthritis that usually occurs in people over the age of 50. Next, we'll talk about arthritis related to rotator cuff tears, or rotator cuff arthropathy. On the left-hand side image, we have a normal rotator cuff, and we can see the ball is nicely centered in the middle of the socket. The X-ray on the right-hand side of the slide shows a shoulder with a massive rotator cuff tear. A chronic rotator cuff tear can get larger and lose its function to keep the ball centered in the socket. The torn rotator cuff cannot be repaired surgically because the tears are too large and the tissue is of poor quality. As a result, in these cases, the ball of the shoulder migrates upward, making normal movement very difficult. This is known as rotator cuff arthropathy. We treat rotator cuff arthropathy the same as shoulder arthritis. Symptoms commonly associated with shoulder arthritis include pain, which is the most common symptom of arthritis. It is aggravated by activity and progressively gets worse over time. Night pain is common and sleeping can become very difficult. Arthritis can also cause swelling and stiffness in the joint. Over time, the range of motion of the joint can decrease. Eventually, the cartilage on the joint surfaces wears away, leaving exposed bone. As a result, you may feel a grinding sensation as you move your shoulder. This is known as crepitus. So, what do you need to know about arthritis? The first thing you need to know is that pain does not always correlate to X-ray findings. Sometimes mild arthritis can be very painful, and people with severe arthritis on an X-ray can have very little pain. Recommendations for surgery will be based on your clinical presentation and not based on your X-ray alone. Arthritis generally worsens over time. Joints will get stiffer and lose range of motion as the arthritis progresses. There is no cure for arthritis, but it can be managed. Symptom management is the goal of treatment for shoulder arthritis. It's important to understand that treatment may improve symptoms, but might not provide complete pain relief. Surgery is the last option when non-surgical management can no longer control pain. If you have any of these conditions, you may not be a candidate for shoulder replacement. Shoulder arthroplasty, or shoulder replacement surgery, is a good surgery for pain reduction of a painful arthritic shoulder. Range of motion and strength are not guaranteed after surgery. Most patients get up to shoulder height and usually regain the strength they had preoperatively. Shoulder replacements are not designed for heavy activity, manual labor, or high-intensity recreational activities. Impact activities like chopping wood or chipping ice can cause loosening of the joint. Long lever lifting or strengthening should be avoided, as this can also cause loosening and excess wear or rotator cuff related pain. It is extremely important to protect your shoulder replacement after surgery. Consider your shoulder replacement like a new pair of shoes that needs to last you the majority of your life. How you use your shoes determines how long they will last. Generally, shoulder replacements last between 10 to 15 years. Revision rates are higher in patients under the age of 65. This active group wears out their shoulder replacements faster than less active individuals. Revision surgery is never as good as the first replacement. There may be no surgical options after a revision. These procedures are best done in an older population as revision rates are much lower. In other words, the longer you can manage your pain without surgery, the better. This concludes our video. We hope that the information shared with you today is helpful in managing your shoulder pain. For more guidance, visit our YouTube channel, where you'll find video demonstrations of exercises to support your shoulder health. Thank you for watching and for your attention.